Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Welcome everyone to Echo this week. We have a very exciting session. First, I'm very excited to have Dr. Joe Merrill back with us to talk about motivational interviewing. This is a talk I saw Joe give for Hep C Echo, and I was really impressed. There were really great reminders for me and I think for everyone. Joe, go ahead. Thank you.
Great. Thanks for having me today. So today I'm going to talk about motivational strategies for behavior change, and these are things that I need to be remind myself of, and they're very common in primary care and HIV care. We see tons of behavioral issues when we're taking care of people with HIV or in primary care, whether it's drug or alcohol use or tobacco, or whether it's medication adherence issues, diet, exercise. All these things are behavioral issues that we can interact with our patients around and play an important role in addressing them and how they impact our medical outcomes. So especially in HIV care, we focus so much on adherence to medication, knowing that those medical outcomes are so improved with good adherence, but there's also all these behavioral topics that can impact adherence to medication. So we often have to take a step back and help our patients in those ways. So motivational strategies really trying to equip us with the tools to do this in a more effective way. When behavioral issues come up, think, okay, I got to practice my motivational strategies, and it helps me a lot. So this is really not motivational interviewing, what I'm going to talk about, because I'm trying to apply it to briefer visits in a primary care setting. But the overall philosophy of it, the whole emphasis of it is something that I think we can apply. It's just motivational interviewing, and it's official, takes some more training, takes an hour per shot. It's a little bit different. So, but the idea still is that change is going to come from the patient. Our goal is really to enhance the patient's motivation and their commitment to change, and that's really what we're there for. It also provides us with options when change doesn't happen. You make a plan, the patient comes back, no, that didn't happen, or there's resistance within a conversation to behavior change. That should also kind of tweak your brain to say, okay, this is resistance. How am I supposed to react to resistance in an effective way? And I really find that these kind of techniques increase how effective I am in these discussions. And I think it's a lot more fun too to kind of have some tools to use when the interaction going gets a little bit rough. So I'm going to talk about two steps in behavior change counseling as applied to sort of a primary care setting. Well, first is enhancing motivation to change. And really the things I want you to think about are, how can I get my patient to do change talk? And we'll talk about what that is. And then how to help the patient focus on the decisional balance, the pros and cons of change. And that's really for folks who are thinking about change, maybe not thinking about change, but you're thinking about change in their life, how to get those conversations going. And then the second step is really developing a plan that's maybe what we would call patient-centered or a collaborative plan. These are the steps after the motivation's in place. They want to do something about it. And that's really engaging patients in self-management. So change talk and resistance are two terms that are used in motivational interviewing. The idea is, as I hear myself talk, I learn what I believe. So the goal here is to get the patient to be talking in language that supports behavior change. So whatever they're saying that is about their readiness or how important it would be or how they might do it, all that is change talk. And it's kind of the flip side of resistance. Resistance language is opposing behavior change. And we often find that when we suggest something about behavior change to a patient, they may react against that, or I could never do that, or I don't need to do that. And so when you hear that kind of language, you realize what you're hearing. It's resistance talk, and there are techniques to use to try and go the other way. So patients who do express more resistance within clinical encounters are less likely to change. And it's also true that clinician style that is more confrontational, that's kind of the most, you gotta stop drinking kind of thing, actually promotes resistance. People swing around and say, no, I don't. And confrontation doesn't have to be the, you gotta change or you're gonna die kind of thing. It can also be just merely education. Do you know that alcohol affects your liver and this is a reason why you might need to drink less. Even that kind of educational stance, assuming the patient even doesn't even know that already, can actually be a kind of confrontation and maybe less effective than some other approaches. Motivational techniques are really trying to promote change talk and then minimize or diffuse or move away from resistance talk coming from the patient. So meeting resistance, really, they talk about rolling with resistance in motivational interviewing. You never want to meet it head on, meaning that you want to argue with the patient. That's not in the spirit of motivational interviewing. There may be times that confronting a patient about something could be helpful, but if you're trying to do motivational strategies, that's not the way you would do it. Actually, the best response to resistance is usually a reflection. And what that could mean is that you are expressing to the patient that you heard what they said, and that's an important aspect of generating a good rapport. But it validates the patient's experience. It can also make resistance talk less and open up the possibility of change talk if the patient feels like, oh, that provider heard me, knows what I'm meaning by this. Maybe I can also think on the other side of the decisional balance. And one technique that people use in that is amplifying. So we're talking about alcohol. I'm not going to quit because it's not a problem in my life. You can't imagine life without drinking. That's kind of an amplification of what they said, but sometimes you'll get actually, that's not what I meant. I meant something else, and you'll get something clearer or maybe even something about the problems related to alcohol for them. So just think about when you're meeting resistance to reflect what the patient said, even amplify it. And then exploring the pros and cons of what the situation is now can be helpful. A patient provides some resistance talk, go with it. What are some of the good things about how it's been going in terms of that behavior? What are the good things about drinking, or what are the good things about whatever your exercise pattern is? And then maybe instead of saying what are some of the bad things, you could say some of the less good things. Might be a way of opening up that other side of the resistance talk and getting people to talk about change in a more positive way. And talking about, so change talk could include problems with the current situation. And so if you want to ask for change talk in a very direct way, what are your concerns about I'm using alcohol, might as well keep going with that. Tell me about your concerns about your alcohol use. Now, if they don't have any, they may say, I don't have any, but most people have something that they've been told or have heard about or that they may be concerned about. And whatever the answer to that question, that is change talk. And then, or tell me why you think you might need to make a change and how much you're drinking. It might not be stopping, it might be how much. And then if they give you something, then go with that and tell me more about that. Tell me more about is actually the best question in medicine. You should be asking it all the time. It's an open question, but it directs the patient to what you're interested in. So tell me more about that issue you have. You said that your partner sometimes gives you trouble. Tell me more about that. How your partner gets on you around your alcohol. That's going to be change talk. Then the other thing you can do is just reflect what they said, what their concern was. Basically, the goal is to pick on something that the patient has decided is a concern and get them to talk more about it. And then what else? What else are you worried about? So that's kind of, you can say that the next time you see a patient and the behavioral issue comes up, my goal is to see if I can get the patient to do some change talk. And then another way to do the change talk questioning, how important do you think it is for you to change your drinking in this case? Maybe the patient says, well, it's about a 2 out of 10. Not very important. Well, why isn't it a 0? And that's really the way I use the question. I don't usually ask about why isn't it 10 or what would it take for it to get to 10. Some people use that. I like okay, why isn't it a 0? And that's asking for change talk. Why isn't it less important than that? Things seem to be going pretty well for you. Why would you want to change? Motivational interviewing often uses that kind of language to see if you can get the patient to make the change rather than you providing this is why you need to change. So once a concern is stated, again, open questions, tell me more about that, reflecting it, and what other kinds of concerns do you have? So that's change talk stuff you can do. And then the second part, so we talked about getting the self-motivational statements, what concerns you about it, the importance scale, and then the second part is more developing a collaborative plan. This is, so, Doc, I just got to quit smoking. You've been talking to them for 5 years about it, and they come in and, my dentist told me that my cavity would, would get better quicker if I quit smoking. I got to quit smoking. Okay, it always feels great. You've been trying for 5 years, and then somebody else gets all the glory. But that's kind of where we're at. What do you do when the motivation is there? And using the confidence scale is one way to do that. This isn't really. I call this basic conversation, trying to do a patient-centered plan. One of the things about transitioning to making a plan is that you want to make sure the patient's ready for that. If they're not ready, you're going to get resistance. So they might miss their visit, they may be guarded or indecisive or frankly resistant. And sometimes patients, who are trying to quit smoking are coerced by the heart attack they just had, and they may not have dealt with that. So it can be helpful if somebody is sort of in a coerced situation. This happens in the DUI situation, they have to go to treatment. It can be helpful to just get that on the table and talk about it, because they may not be really ready to make a plan. They may have to process that first. And patients who are ready to switch, they're doing change talk, they seem resolved, they start to imagine what it's like to be in a different place and to have different behavior. So those are kind of, it's pretty common sense, but you want to have the patient be ready before you're starting to make a plan. If you start saying, so what are we going to do about quitting smoking, but you haven't done that, you're not going to get anywhere. So then you can summarize, like you may have gotten some change talk, you may have gotten some resistance, and you can summarize that. On the one hand, you had this heart attack. On the other hand, you've been smoking for 30 years. So there's a lot of ways that you can kind of summarize and hold that decision. Where do we go from here? And that's really just putting it back on the patient. What do you think you might be able to do about this? And get their ideas first. You may have 20 ideas about how they could quit smoking, but the goal here is really to not do too much education, but really get it from the patient. So building that collaborative plan, let's say you're talking about a goal of getting their diabetes under control, and what is the goal? I need to lose weight. That's the one that the patient wants to go after. What ideas do you have? And again, you try and work with the patient ideas first. Want to get it specific. That can be down to choosing an activity. Maybe it's exercise, maybe it's diet. If it's exercise, what kind of exercise, how often, with who, how are you going to, and brainstorm what each piece of it, so that the patient ends up not with I got to lose weight as they leave the office, but they end up with okay, for 3 times this next week, I'm going to call my friend up who lives next door, and we're going to go on a walk. So your goal is really to try and focus it down to something concrete that you can write in the chart, said this is what we agreed on. You can check in with them later. And then considering barriers to what that will be. What will it be like to call up your friend and make that plan? Will that be easy or hard? And then the confidence scale is a motivational interviewing idea that you can use. How confident are you that you can make this change? And this is relevant to the making of a plan. So you could say, I'm 5 out of 10 confident. Why aren't you less than that? Does sort of encourage that, well, I'm really pretty motivated about this. I really do have a friend who can help me get out and walk. So it encourages sort of what their self-efficacy, what their resources are. And then why are you not more confident can help identify what the barriers are, what's going to get in the way, and then brainstorming about how they might get beyond that. Again, all of this is very common sense. We do it a lot, but sometimes I think it helps to kind of be reminded that, okay, I'm trying to make a patient-centered plan, and these are some techniques I can use. So then the follow-up visit, I really find that it's helpful for me with the behavioral change issues to document it in my notes so I know where we got to. The last time, it may be, we talked about smoking. The patient has no intention of quitting ever, but recognizes that they need their CT scan for cancer screening and is willing to do that. So that might be the behavior that we ended up with, that they're willing to do that, and then they'll get it from the cancer care people will get on them about their smoking too. That to me is a plan. But I've documented it, and I know where the conversation ended up at the last visit. And sometimes it's really helpful especially if there's been partial success or some change but not a lot. It may be helpful to renew that, spend some time with change talk. Remind me what it was that made you want to change this behavior, and get them to do a little change talk while they're there. It's free. And then you obviously want to communicate, especially in a patient who hasn't been able to follow through, that it's up to them. It's not about you're trying to force them. It's really about what they want to do with their life and their behavior. I think one of the tricky things for us as physicians or as any medical provider, we're encouraged to educate our patients a lot about what they should do and what is healthy, and we kind of have our spiels about that. And I think when you find yourself starting to educate the patient, I think that's a time to really check in with yourself. Is that what the patient needs? Or maybe they do need some education. Maybe they've tried the gum and the patch and they don't know what else to try, and maybe they haven't tried them both together, or maybe they're ready for a medicine, and maybe you do need to educate them about their options. But in the motivational interviewing stance, it's pretty much, would it be okay if I had told you a little bit more about what some other patients of mine got benefit from who are in your situation? Ask them, see if that's where they're at before giving too much education or advice. But you do sometimes need to give that advice if they are struggling or need some more help. But really try and get it from the patient as best you can. They often know better than you what they need. So this is for these motivational kinds of strategies, I think you kind of have to have it in your head that you're going to try, and you have to kind of have it in your head what you're going to do. And then you're going to bumble around, and I bumble around all the time with these conversations and end up with the patient not wanting to do anything different, but still I've given it a try, and maybe I've gotten a little bit of change talk, and I know that change talk at least has planted the seed, so when the dentist says you got to quit smoking, they'll be ready. And then enhancing motivation to change, eliciting those change talk. Tell me what your concerns are about this behavior. Do the importance scale, see how that goes for you. Everybody's got to develop their own style with this. And then developing a plan. How do you want to make that change? And then being specific, a realistic plan that you can write down, and then maybe using the confidence scale a little bit more. So these are just a couple of references for people who want to learn a little bit more, and I encourage you to read more about this if you're interested, and practice on your patients, because that's who needs it, and so do you. So thanks.